Hello, my name is Marios Patihis. I'm a professor here at the University of New Mexico, where I'm the area chair of computer engineering and the director of image and video processing and communications lab. Today I'll be talking about UNM research related to telemedicine, mobile health, and big data. Here I have a little system diagram that shows mobile health application scenarios. As you can see in the center, we have the network starting from 2.5G all the way up to 4G. And what we have is the hospital on the right, where the medical expert could respond to different events. We have the patient example here who can suffer from chronic diseases or mobility problems, or firefighters. Most of our research is associated with medical video communications, such as shown here, which includes the use of ultrasound video to arrive at a diagnosis. The goal here is to get information to the hospital, in this case through a wireless communication system, to allow remote diagnosis. We can also have multiple doctors provide multiple opinions. Telesurgery, if a doctor is being consulted on how a particular operation needs to be handled. Triage, where we're looking at determining what to do with the patient during an emergency response, or educational purposes. Recently, we have the use of electronic health records that will be available in mobile healthcare. Also, we have smartphones, tablets that are being used for accessing the data, and that it becomes very important in mobile healthcare applications. In disaster crisis management, we will be focusing, in this case, on emergency scenery video. In this case, situational awareness video that shows what is happening. And as I said earlier, most of our research will be primarily be focused on the use of ultrasound, what is called stroke ultrasound, to respond to stroke incidents. Another area, though, that is very interesting and will be covered in the course at UTech is the use of body area networks, especially for chronic diseases or mobility problems. Okay. Here is an example of the e-emergency services that we're working with at UNM, collaboration with the University of Cyprus and Imperial College in London. We have a telemedicine unit that can be employed in an ambulance. We study this a lot. I won't show you any examples today, but we could, for example, we study what it means to transmit video from a moving ambulance, and what kind of networking issues appear in that communication, or home monitoring, or even from the sea. Okay? And, this is an emergency healthcare, but as you can imagine, there's also patient monitoring. And all of this going through wirelessly most of the time to a doctor who could be anywhere, anytime. In this case, is looking at a little tablet, or to a regular base unit in a hospital. Yeah. A lot of our research is focused on stroke response. Here we have a little example of what is happening with stroke. I won't go into it, but what is important here is that we have a carotid artery over here shown, and it develops plaques. We will be looking at those later. And we really want to see if these plaques are dangerous. If they are dangerous, then those plaques will break. Thrombus, in this case, will go up and travel up towards the brain area and cause significant damage. We have over about 800,000 cases per year in the United States. It accounts for 1 of every 18 deaths. And we can have significant long-term disabilities. Okay, And most of this initial diagnosis, at least, is covered by ultrasound. Here's a little system. The boxes meant to characterize engineering systems. So you can see we have the video, okay, plaques, or another emergency case that we've done research here at UNM is abdominal aortic aneurysm, where we have very fast emergencies in that case if something like this happens. We want the video to go through a wireless channel, and the big thing about going through a wireless, let's say in cell phones or any other non-wired connections to the internet, is that there will be a lot of losses, right? In this case, we're showing that video is being broken into little packets that are lost during the transition, right? And on the other side, we have users, doctors, looking at the video. So in order for these communications to be done effectively, we have to provide what is called error resilient, which is a methodology for surviving these losses, right, during wireless transmissions. And we've done a lot of research here on what is called region of interest encoding, where we allocate a lot of bandwidth, and we provide what is called redundant slices for the pieces that are not to be lost during transmission. Okay. Again, the clinical video quality needs to be very high in order for the doctors to be able to use the video that we are transmitting. Okay. Here we want to describe a stroke ultrasound video communication system. We have the original plug video that is collected at the scene, emergency scene, and we want to communicate the plug video. We have a segmentation system which basically identifies the location of the plug. You can see its outline. And we use what is called flexible macro-block ordering, FMO, which is a method to encode different pieces of the video. Okay? By using that, in this case, you can see that the red region is where we expect the plug to move. It will capture the motion of the plug and the stenosis, and that part needs to be very carefully protected. We should not have significant quality losses here, or any at all. While the green regions, within the green regions, we want to monitor those. We can put up with some losses, and outside the green, we can put up with significant losses. So basically, we want to allocate most of the compression bandwidth to the main region. And after you do all of that, then we need to take into account the fact that pieces of the video are going to be dropped. Here you can see, boom, this is a loss of a piece of the video, which is very, very typical during wireless communications because they tend to be noisy communications. Not everything gets through, and the video encoding for telemedicine really needs to take that into account. And then, of course, on the other side, we want to see a reconstruction that is very close to the original, that does not compromise significantly the video quality, where there are regions that we want to see that should not be compromised. Now we're going to cover an example of ultrasound video transmission of an atherosclerotic plaque, shown right here, in a communications channel where you have 15% drops of the packets. In other words, 15% of the packets being communicated in this wireless channel do not make it. Only 85% get through. And this is typical of a wireless network, okay, that you will drop some. Okay. In this example, we are using H.264, and we're demonstrating some of the new technologies developed at UNM in collaboration with the University of Cyprus and Imperial. And here we have, notice how we have flexible macro-block ordering is new technology for H.264, and it requires 682 kilobits per second, which is a relatively high bandwidth, as opposed to the methodology that we will show that we have developed that drops it to 50% less and only 274 kilobits per second, and also will perform much better than the original H.264. As you will see here, the plug will disappear right there, and this happened because there was no error recovery in this original encoding. Let me repeat this. As you could see, there are some artifacts everywhere, but most importantly, you have lost the plug, and the errors appear randomly everywhere. In the proposed approach, we will demonstrate right here, we use what is called redundant slices, extra slices, to protect, essentially allow the system to recover from the dropped pieces. So as you can see in our example, we are not losing any information, and the physician will be able to see the plug and the stenosis, and therefore the video remains useful despite the problems in the network. Okay. More recently, and this is a paper published in the Signal Processing magazine last year, IEEE, one of the best journals in this area, we're showing the great promise of a brand new system, video coding system. It's called the HEVC, High Efficiency Video Coding, that will become the standard in the next 10 years. We've been working with early versions of this system. Okay, so here we have the savings of the new system, HEVC, over what is currently being used. Most hospitals and original DVD players are based on MPEG-2, and there's a 70% reduction in storage requirements over MPEG-2. Some relatively more modern standard of this century, the MPEG-4, and you can see that even MPEG-4 is, you can have significant reductions with the new standard with HEVC. And then over here on the iPhone side, you can get 35 to 40% with the very latest mobile devices that, assuming they're using state-of-the-art H.264 encoding. So this new standard promises, here tested with 10 videos, which were running at 50 frames per second, promises to save a lot. And here at UNM, we looked at the completely new video compression systems that are based on what we call drastic. So we have taken a rather dramatic approach to video compression, where instead of just the standard classical video compression of looking at compressing the entire video in a certain way, we want to be able to adjust the video compression mode to provide the users with options that provide quality in many different environments. So let me talk to you a little bit about this. We're talking about dynamically configurable systems. Dynamically configurable meaning that we allow the hardware and software to change. This is completely new because we are looking at computers that really rewire their own hardware. In other words, they really are able to become different computers inside, in hardware. They will have more multipliers, more adders, or more hardware, as I shall demonstrate, to perform better. And then they're allowing themselves to turn those pieces off or to save power. So we have 4 different modes that we consider. Number 1 is, very interestingly, the minimum power mode. You can imagine if you're using a mobile device and your battery life is not significant, and you still want to, let's say, the doctor to communicate with the patients, then in the minimum power mode, you allow the system to conserve power. Don't consume very much. You're minimizing that, while still you maintain a level of quality that makes diagnosis possible. And the bit rate here, in other words, the bandwidth, stays within the bounds of your network. Okay? So we have this minimum power mode that the users will be able to switch to save power. Another one is what's called the minimum bitrate mode, which essentially tries to compress for the minimum amount of required bandwidth. If you can imagine in a situation where there isn't that much bandwidth, then you really want to be able to minimize your bandwidth requirement, because otherwise you won't be able to communicate, again, subject to constraints on the quality. The next one is, of course, you also want to, similarly, if you have many users, or you're looking at, doctors looking at multiple videos at the same time, you want to minimize the bit rate for, let's say, cases that have already been reviewed and you're just running in the background. Okay, another one is like when at the beginning of an exam, the doctor will want to have what is called the maximum image quality mode. Here, you really want to allocate the best quality of your video, because you're doing an initial review and you really want to see all the possible things that went wrong. This is a maximum quality mode that within reasonable power and the available bandwidth, you try to provide the very, very best quality. And then a typical mode that tries to balance all of them. And as I said earlier, our research here allows you to switch between those different modes. The user will be able to change how they encode their video. Here an example of applying these ideas to what is called a discrete cosine transform, the DCT. DCT is the fundamental component that is in every image and video compression today, including JPEG, MPEG standards, H.264, and the new HEVC. What we have done is that we have this called dynamic hardware block that essentially changes the hardware. It changes the transformation. It really internally inside the computer. We allow it to have more multipliers, more others, to perform larger transformations, or smaller. In addition to allowing the users to change the quantization, which is done in software, right? So this is really innovative research. What we're looking at is we adjust the software and the hardware as opposed to just changing the software, the programs. And this really has the effect of allowing the users to control the different modes. Okay. More recently, we're doing work with HEVC, which involves this complicated system diagram that I won't go into. In here, we have different predictions. We have implemented, for example, all of the different directions and the different sizes of the blocks that the video has been broken into. Okay. One very important example here is, notice that we're demonstrating on a standard video. Unlike the standard video compression that allows you to operate at a single point, we have all these beautiful surfaces. You'll see these different points where the user can apply the drastic modes. For example, here the PSNR measures image quality, so the user can select higher quality, or if they want to play the video at a higher frame rate, they can select it here, and based on the available bandwidth, the hope is that the user will have a solution along the surface. Of course, you can change the time by changing the hardware and by a more advanced computer, or if, for example, if you want to encode for particular different rates. So this joint, all of these points show an example of what the user can do under drastic. Okay. Another way to look at it, let's say after when the doctor is unavailable, or if the bandwidth is unavailable, you can do the analysis locally at the emergency scene, right? So here we have very recent research that we are doing where the computer, in the absence of a doctor, tries to help the diagnosis by doing it locally. In other words, computer software has been trained with the help of the doctors to provide the diagnosis on the fly without the need for communication. So it's a completely different approach where if the communication bandwidth is not there, then we want a computer to help us analyze the motion. In this case, users can help locate the plaque on the video, which is then estimated, the motion is estimated, and then we want to essentially tell the users, in this case emergency technicians, what we think about the patient, right? Here's a really nice example showing you that this is an example of a very stable plaque because most of the motions are concentrated in this blue region. This work with the Imperial College, Professor Nikolaidis, classifies the videos in concordant plaques and discordant plaques. And basically, here we have a very dangerous case because the motions are everywhere. Notice those little green arrows here, computed by our system. And the system also computes these graphics here that show that we have a dangerous case, right, versus a case here where your motion is pretty solid. Okay? In this case, we're looking at statistics over the entire video. These are computed. Little point captures the median velocity over different frames. And we have this scatter plot. These are the patients that are more or less stable and far less critical to transport to the hospital in terms of the plaque. In this case, the motions are concentrated to the left. These are dangerous cases where, as you can see, there are very dangerous motions, extreme points that occur here at 6 pixels, 5 pixels down to 2. And as you shall see, the computer tries to classify the case based on these points here. In this case, pixel motion of 5 down to 2. So by adding them up, you can see very nice separation. Here is relatively limited motion for more stable patients versus a high-risk case that has statistics that are more dangerous in this total sum, showing significantly more motion. And we're able to do that. This was tested for 35 cases where we have 13 discordant, which are difficult cases, versus concordant. Okay? And the computer was able to tell that these were dangerous cases. Another way to do the analysis locally is to essentially analyze a single image. This is work that was done by Professor Mare, who is right now in Lima, Peru at UTEC. And we hope to also have more work in this area. In this case, during his PhD, Professor Mare, he worked on the MFM texture analysis methods. And in his case, he was able, you extract information, you encode the image information using what is called MFM analysis methods. These are features that human eye cannot normally see, but they are very useful for the computer. And a computer software called classifier takes what was been extracted and tries to make a diagnosis out of it. We looked at many systems here. The one that we're going to show is the one based on retinal image analysis, where the goal is to screen the entire population beyond a certain age. We want to avoid people from going blind, so the hope is to screen for diabetic retinopathy. These kind of technologies are being investigated for plaques, and then of course we've seen an application in multiple sclerosis where we could find evidence in this analysis of very dangerous lesions versus lesions that are not so dangerous. And this type of classification cannot be done by human, but by collecting the images in time, we could find that evidence earlier. It's been applied to cancer, gynecological cancer, but also more recently also mammography. Here's an example for Dr. Mare. This is a retinal image. This is the original picture that, although it's been analyzed by humans in its current form, using these AM/FM techniques, computer turns that into binary formation of different extractions. For example, as you can see over here, these white pixels were colored to show where blood vessels are there and analyzing their structure. Notice how the computer decomposition produces many different images, extracting different versions, and then they're used to classify. So this is the final output, showing you a great promise of the system. In this case, we have 4 plots. The ideal system, the one that never gets anything wrong, will approximate 100%, and most doctors will not even be able to get there. But as you can see here, case after case, computer analysis is in great agreement with the doctors. In this case, we have risk 0 meaning normal, 1 is early stages of disease, 2 is higher, and 3 are the most advanced cases. And computer was asked to classify, let's say, normal versus abnormal or early abnormal cases, and you can have excellent results where you get all the abnormal cases, but sometimes it's been classified, some of them as abnormal where they were normal, and 82% there, the specificity, those require extra exams. So notice that the high sensitivity means that the system is trying to be conservative, identify all of the abnormals while still allowing misclassification of some normals, and extra exam will show for the some low percentages of normals that were misclassified will clear them. Okay. More recently, we're working on what is called big data. Big data comes very naturally in medicine, especially in what we call video database communications, which are very large-scale databases in most hospitals that store videos. And more obviously, based on what we said before, these videos, video databases need to be communicated, and they need to maintain a very high clinical video quality. Otherwise, there's no reason to even store them, right? And we want to allow the users to review the videos based on drastic, like have high quality modes, but also like lower bandwidth modes in case that a doctor is in a region without too much power or bandwidth. So we want to transmit anywhere and pretty much any time. I mean, you need to be able to review them on both very small and very large devices. So anywhere at any time, big data sets communications is what we're working on right now. Finally, I would like to thank Dr. Yubing Zhang, completing his PhD at UNM here in May 2014. He produced the original drastic modes. Hamed Nazrabadi worked on the motion estimation that we showed earlier. Kangaharam Esaki and Vengares Chadla are working on the big data concept. The ultrasound videos that were used were provided in collaborations with Professor Konstantinos Patikis from the University of Cyprus, Andreas Panagidis, and Professor Nikolaidis from Imperial. And then the diabetic retinopathy example was done by Professor Mare, who is now at UTEC in Lima. Thank you.